Younger,
Adolescents.
often adolescents, often female. So when you first consider a patella instability or subluxation, just an assessment of where does their patella sit relative to the femoral condyle. So if you have someone with a patella alta, so they're sitting higher in that groove, then you're going to get a little bit of extra movement and they are more prone to subluxation or dislocation. There's nothing you can do about that, obviously. You can't change their anatomy point of view, but it's having an awareness of that. Also, if you have someone who has a history of patella instability, then they're often very apprehensive to you touching and moving their patella. So it's really important that you do have a clear discussion about what you're going to do and do it on the unaffected side, but remembering if they do have that anatomical change, they might feel a bit icky about the other side as well. So just proceed with care with this. How much information do you need to confirm your diagnosis? Essentially what you want to get with this test is either a feel of how much mobility they have through their patella. If it's starting to if it's post dislocation, starting to get a feel of if that MPFL is healing and they're starting to get some nice resistance to a lateral glide, or if you want to sort of rule out that the patella is a part of the problem. So always with your ligamentous tests, you're not always using them when you suspect the pathology. Sometimes you are using them to clear that as a problem. So you're using your test to rule out. And in my knee joint assessment, if I'm seeing someone who comes in with knee pain, I will check their swelling for everybody, check their passive knee range of movement. If that knee range of movement is full, then I will test their PCL, ACL, lateral and medial collaterals, and their McMurray's. So then I have an idea of the structure of their knee, and that literally takes me a couple of minutes to do on both sides. So I have an idea of the stability of the structure of their knee. That might also be something that they are concerned about, and you can verbalise to them, you have a nice, strong, stable knee. So we don't need to worry about your structure. What we need to do is now work on the other things that are contributing to your knee, whatever, pain, feeling of instability, whatever. But if you can confirm that their structure is sound, then it's a less worry for them, but also you've proved to them how much their knee joint moves. It may be like within our group, and if you felt different knees, some people have got very stiff, tight knees. Other people have got a bit more play in their knees, but still a solid end feel. So it may just give you a bit like the shoulder. If they've got extra movement and play in their knee, they may just have to work harder at controlling their knee joint movement, as opposed to someone who's relatively stiff and they just sort of have to work on their strength. So it can be a slightly different approach or emphasis in approach. Okay, now, patella, back to the patella. So, with the patella, if we're thinking that someone has an unstable patellofemoral joint, the first direction that we're going to assess is medial. So we're going into safety. So we can assess at 0 degrees. Now, which position is going to be more stable, 0 or 30?
0.
30.
For the patella.
For the patella. So it's going to be sitting in that femoral groove. So for starters, we might just go and give a medial glide in 30 to get a feel in a much more stable position. You can then extend the knee, maintaining that medial glide. What would you expect the patella to do as they come up into 0? Go further. So it's coming out of that trochlear groove. You should feel it basically in that trochlear groove, and as you move into knee extension, it's going to increase the medial glide. So we were happy with that because that is also a feeling of safety, right? So then we can go and do the opposite. So if we're suspicious of a lateral subluxation, you might do it in a flexed position first just to get a sensation of what it feels like when it's still in that trochlear groove. Now, you'll notice I've still got a thumb on the lateral side. So if it started to move and you felt apprehensive, so that's a positive test as well, similar to the shoulder apprehension. If it moves in that direction, you want to have that safety thumb there so that you're showing to them, I'm controlling this, I won't just let it pop out. You're not doing a really strong, whack and push that way. It's just a feeling and a glide into my hand there. Again, we're trying to get a feel of the MPFL. Does it seem to stop that glide in that position? Then you can maintain that glide. I've still got my hand on the lateral side of the patella and come into a less stable position, and it might come more laterally as you go. Okay, so in a position like this, you can maintain a medial glide and move into extension and flexion, feeling how that changes over that period. It should feel comfortable. It's like a relocation test if we're talking about analogy in the shoulder, okay? If we do a lateral glide from this position of safety into a more unstable position, it should increase, but you still should get a good feel that that is not moving anywhere. And as you go into a flexed position, it should sit back into the trochlear groove. Now, you can play with flexion extension, and I think it's good for you to feel the difference with those flexed and extended positions, because essentially what you're doing is feeling the restraint of the bony contours, and then in an extended position you're feeling the restraint of the ligamentous contours. When it comes down to patella dislocation, you may have a injury to the undersurface of the lateral side of the patella, so the patella articular surface. You may have an injury to the lateral femoral condyle on the medial aspect as the kneecap patella has dislocated. So you can have bony fragments and contusions here. And then we're looking also for ligamentous injury of the MPFL. Now, people can sublux and dislocate without damaging the MPFL, so their prognosis will be better than someone who has a patella alter and damages or tears the MPFL, because they've really reduced their structural restraint. Someone who just stretches into that position but maintains an intact MPFL should do well with a conservative management program. If they have a bony injury and the bony restraint to lateral glide has been affected, then it's going to be very difficult for them to restrain their patella in that direction moving forward. So that's when they may go for, with a bony injury, they're much more likely to do a surgical approach, repair that and probably repair the MPFL. And the surgeons that in my city, they often like to do a tibial tubercle transfer at the same time. So it can be quite a significant injury, a significant surgery. So having a discussion around what the treatment options are can be really useful, and to what extent you want to go with that, because obviously a triple T surgery is a significant rehabilitation process. And I've worked with, and people I've worked with have been young females, so mid-teenage years, one managed very successfully conservatively, and the other one we managed her conservatively for about 3 years because she didn't want to have surgery at that stage, so she modified her activity, and she had a triple T and reconstruction about 3 years down the track, so she's now fully recovered from that. So you can manage it either way. So positive test is that apprehension, obviously increased glide and lack of end feel. If someone has had a dislocation in this position, if you put a lateral glide on, they'll probably feel pretty uncomfortable pretty quickly. So you get a lot of information from just doing your patella glide in this position, first in a medial position and then a lateral. But they might not even want you to do the lateral. So just make sure you always work on the safety side of things and have that lateral support of the patella. Okay, let's work on that. Thank you.